Welcome, everybody. We've got a good group tonight. We've got 7 of us here in the fellowship hall, and what have you, 10 of you on screen. So welcome, welcome. Well, as you know, tonight our topic is end-of-life decision-making, and we're really pleased to have Dr. Ben Stultz, who's a new member here at Redeemer. He and his wife Jessica and their 2 girls, who he's going to tell you more about. But this is a real interest of his. And so before we start, I usually have a meditation, but what I did for meditation tonight was I looked for some meditation in scripture about end-of-life decision-making. And what it's in asking what the Bible says about end-of-life decisions, the Bible doesn't specifically address end-of-life care. It does talk about how to treat others and the importance for all of us to honor life. We can draw on these passages from the Bible, and one of the most well-known is Matthew 7:12, the Golden Rule. And it's actually titled in the Bible, the Golden Rule. And it says, "So whatever you wish that others would do to you, do also to them, for this is the law and the prophets." So we hear a lot about taking care of others, but taking care of ourselves is equally important. And when it comes to end-of-life decisions, only we know what we want, and to provide for our kids and our loved ones can be a big help. Another verse, what does the Bible say about making choices in life? "Trust in the Lord with all your heart and do not lean on your own understanding. In all your ways acknowledge him, and he will make straight your paths." Proverbs 3 verses 5 and 6 is what that was about. And then the first thing any Christian should do when faced with a decision is what? What should we do as Christians?
Pray.
With God. Pray and ask God to help us. Exactly. What is end-of-life decision-making? And Ben's going to talk more about this, but it's just a brief statement. End-of-life decisions are the choices that we have to make about what life-sustaining measures we want to receive if we have a terminal illness and we're not able to speak for ourselves. End-of-life wishes are often put on the back burner. And if we try to talk to our children about it, sometimes they'll say, "Oh, we don't want to talk about that." And it gets put off until maybe one day it's late and we haven't done it. Comforting scripture about death is from Psalm 73. "My flesh and my heart may fail, but God is the strength of my heart and my portion forever." John 16 tells us, "So with you, now is your time of grief, but I will see you again, and you will rejoice, and no one can take away that joy." And then lastly, Philippians 4, "I can do all things through Christ who strengthens me." So just 2 more verses. What does the Bible say about end of life again? "For the wages of sin is death, but the gift of God is eternal life in Christ Jesus our Lord." Romans 6 tells us that physical death is guaranteed in this world because our bodies are broken and sinful. But if we put our faith in Christ, we will spend eternity in heaven. And then lastly, Isaiah 41 says, "Fear not, for I am with you. Be not dismayed, for I am your God, and I will strengthen you. I will help you. I will uphold you with my righteous right hand." Psalms 34 said, "The Lord is always near to the brokenhearted and saves the crushed in spirit. Likewise, the Spirit will always direct and guide us in our weakness." So there's so many wonderful passages in the Bible, but just to get a start to the end of life decision-making discussion. And can we just have a word of prayer, please? And one more note before I introduce Dr. Stultz. I read an article that said all of us, hear this, all of us should have a good start, if not completion, of our advanced directives and our end-of-life decision-making by age 50. So I'll speak for myself. I'm behind, but it really makes us think. When we go to the clinic, they're always offering the advanced directive books. And they forgot me in a waiting room not too long ago, and I got mine done for the first time. I've taken it home about 4 times, and my doctor left and forgot to tell him to come in and give my vaccinations. And so I sat there and finished my end of life, my advanced directive. So there was a purpose. So tonight we have Dr. Ben Stultz, who's an internal medicine consultant at Mayo, and he's going to tell you a little about his family. And we are so blessed to have he and Jessica and their girls here at Redeemer with us. And again, as I said, this is a topic that he's very well versed on. So please help me welcome Dr. Ben Stultz.
Well, thank you for the very nice introduction. We'll see if I can live up to that hype. My name, as said, was Ben Stultz. Today we'll talk about end-of-life care and decision-making, which is a topic that really frequently we like to not talk too much about. We like to assume that none of us will ever need help or have to defer to someone else, and it's not always the most fun thing to plan for what may happen to you near the end of life, but I think it's a really important discussion to have. So as a brief introduction initially, my objectives today, we'll see if I accomplish all of these, is primarily to answer questions about end-of-life decisions. I have some slides that we'll go through together, but honestly, they won't take that long. I'm hoping that the majority of today can be discussion, because this is an area rife with controversy and conspiracy, and also an area that needs to be really individualized. So it gets difficult to make broad, sweeping statements. My next objective is to understand advanced directives, help you all talk about and understand how to choose a medical decision maker, decide what matters most in life. We'll see if we accomplish that over the next hour and a half, and then how to discuss communication with decision makers. A little bit about me, kind of a personal slide. My name's Ben. I grew up in the Twin Cities. We moved around a fair bit, but mostly like Maple Grove, northwest suburb area. I met my wife up there at a small Lutheran school in 7th grade. We didn't date until college when we re-met, but we've been married since 2015, and we have 2 littles, like was mentioned, 2 daughters aged 4 and 2, Leslie and Raina. You guys will see us here most weekends. We may be chasing one of them, especially the youngest one. She has a fair bit of personality. And when I'm not talking about end-of-life decision-making, I do like to do some other things, like camping and hiking, a lot of house projects, especially once it gets warmer, and then biking, and mostly drinking coffee. This is kind of a little bit of, I do have some credentials in this area, but a little bit about me. I went to undergrad up in the Twin Cities at a small school called Bethel, and then went over to Milwaukee to the Medical College of Wisconsin for medical school. And I've been here since 2020, so we moved here mid-pandemic, where I completed my residency in internal medicine, which basically means training in complicated adult medicine. And then I've just finished up a chief year where I've been acting as a consultant in the hospital. I'll be on service in a week, so hopefully none of you see me. And then staffing in our outpatient clinic in the Baldwin Clinic on the 4th floor. And then next year I'll actually be starting fellowship in critical care, which is where some of my interest in this comes in, because we end up having a lot of very difficult discussions in that arena and run into some extremely messy situations that it's nice to be able to avoid sometimes. Then my last about me slide really just relays a lot of the stuff about this being extremely individualized for all of you. So I like to say I am a doctor, I'm not your doctor. I'm also not your decision maker. So you all have individual lives and individual stories that I don't necessarily know. And if I say something and you say that that sounds like a load of doohickey, then you can feel free to ignore what I say, because I haven't walked in your shoes, and this is an area where a lot of questions come up. Okay, so with that behind us, I wanted to start by just generally talking about some terms and definitions, because you hear a lot of words thrown around when we start talking about end-of-life care and decision-making. The first one is the term palliative care. Does anyone have any experience with this, whether on Zoom, if you're willing to speak up, or here in the room?
Well, my husband was at palliative care, but only for about a month, and then he went on hospice.
Perfect. So she said that her husband, and I'm sorry, I don't know your name.
Elnora. And
Elnora,
will you
thank
just
you.
say that once more, because I want the people to hear you.
My husband was on palliative care for about a month, but then he had to go on hospice.
Yeah. So palliative care is a term that we frequently hear associated with the end of life, and I'm really happy actually you differentiated palliative from hospice. And that's one thing that we'll talk about a little bit. What I'll say is that palliative care is really specifically, and sorry, these are some very, very small words, is specifically medical care focused on relieving symptoms and the stress of serious illness to improve quality of life. So one of the first barriers I wanted to address is some people say if you're in the hospital, you're in the clinic, and they say that we want to talk with palliative care, that can be heard as maybe your care team saying, we don't want to keep treating your illness anymore. We don't think we can do anything for you. And that's not really what's going on. If we're talking to palliative, it means that we really want some more input in how to best control symptoms. Because maybe the treatments that we're doing targeted at an illness aren't really controlling the symptoms associated with that illness as well. Now, the team that takes care of palliative care is frequently the same team that takes care of hospice patients, but those two don't necessarily go hand in hand. In a lot of areas now, depending on different diseases, we're involving palliative care earlier and earlier in courses, not only because it gives people better quality of life and better symptom control, but also actually in a number of diseases we found that if we involve palliative care at the time of, say, particular cancer diagnoses, patients actually live longer. Maybe because there's more people involved, maybe because their symptoms are better controlled, they have a better quality of life, they're maybe able to stay outside of the hospital longer. But I want to make sure that if any of you ever hear the term palliative care thrown out for you or your loved ones, that it's not a negative statement. And unfortunately, because palliative care frequently ends up becoming associated with the end of life, there can be a negative association there. Okay, any questions about that term?
My husband was on palliative care, but for about 1.5 years or something. They just, if he went in the hospital, they came right away and were right there. And
Right under the speaker.
just asked about things. And
Exactly.
made sure things were done right.
Yeah, that's a perfect example. So she said the palliative care was involved in her husband's care for about 1.5 years. They would come in and see him when he was in the hospital, maybe see him in the clinic occasionally, kind of check in whenever anything was going on, make sure that things were going the right direction. And that's really a really good statement about exactly, they're a really good team to have in your corner as you start going through more things. So then just to dive right into it, I wanted to differentiate that with hospice. Has anyone ever had any, I know that some of us have had experiences with hospice. Experiences with hospice, generally with loved ones, whether good or bad, and what kind of stage of life or associations we have with that term. Yeah.
Unfortunately, you're right under the speaker. If I get you over here, you have to get up and move. I apologize, but you're under the, there you go.
Well, Al went into the hospital under palliative care, and then while he was there, he was declining, and then he went on hospice the last 3 days, I think, something in hospital hospice care. So it kind of just went from one to the other.
Yeah. So that's
And the palliative care doctors came out to the hospital and saw him too, and we had a good team, so.
good. Okay, that's really good to hear. So we'll say that hospice is a team, and I'm really happy to use that kind of terminology, and you're still in the hospital, he didn't change locations. Sometimes you hear hospice talked about as a place, like a hospice house, and that's not necessarily what really happens. Hospice is a team that follows you wherever you are, and they're available when you're nearing the end of life. Generally, hospice is available once someone says that we think that your length of life is on the order of less than 6 months. And usually they're focused on providing comfort-focused cares exclusively. And we'll talk about what exactly that means. But hospice is a team, it's an insurance benefit that follows you regardless of where you are. That can be inside the hospital. Most frequently, that's at home. That can be in different facilities. And then if you end up needing to go to something like a quote-unquote hospice house, that's able to be arranged. But there's all kinds of different things that go along with each of those. But hospice as itself, you should really think about as a team that can follow you in different areas.
And some people actually go off of hospice, don't
Yes.
they?
Yeah, so I mentioned my wife, she did her training in social work and worked as a palliative care and hospice social worker up in the Twin Cities before medical school. And they would have people, just because a doctor says that you have less than 6 months to live doesn't mean that we're always right. And you'll have some people who graduate from hospice and it turns out that we were wrong about your disease and it gets better. Or you'll have some people who we keep saying, you know what, you have a pretty serious disease. We still expect this disease to eventually take your life, but it turns out it's going pretty slowly. And in that case, if you live past 6 months, that's not a problem. We just keep saying we still kind of expect this to eventually take your life, but that doesn't necessarily give a hard end point to anything. So people can extend hospice, people can graduate from hospice. Yeah. And the next one that we'll talk about is an advance directive. I'll just jump into this. An advance directive is a legal document outlining your medical care preferences if you can communicate them. So advance directive is a particular part of end-of-life care that we'll talk a little bit more about, that really specifically talks about your medical care preferences. So if you are in a situation where you aren't able to determine an alternate decision maker, and we'll talk about ways that you can try to figure that out, you still can fill out an advance directive and give your future medical team advice on what you would and wouldn't want depending on what kind of situation you might find yourself in. And an advance directive kind of falls under the umbrella term of a living will. Sorry, a living will falls under the umbrella term of an advance directive. A living will is a type of advance directive that specifies medical treatments that you do or don't want at the end of life. These terms most frequently get used semi-interchangeably, and I wouldn't hang up too much on them. And then a power of attorney for healthcare is a document that also is generally baked into an advance directive. A power of attorney for healthcare is a legal document that says someone you trust to make decisions for you if you are unable to make decisions. So you can exclusively do a living will and talk about kinds of treatments that you want. You can exclusively do a power of attorney for healthcare and say, if I'm unable to make my own decisions, this is who I want to make decisions for me. It's really best if we can marry those things, and we'll talk some more about that. Okay, that was my last definition on that slide. I only have one more slide of these, I promise. Any questions on terms that I've thrown out so far?
What's always baffled me a little bit, and I'm a nurse and was for 4 years, we know we should do this stuff, even doubly so as Christians.
Yeah.
Okay? And we don't do it. And the whole thing that I've learned in my whole life is if you do this stuff when you aren't under duress and there isn't a crisis in your family, you can always change this, you know, but we have 3 sons, and, you know, there was a time when I used to try to bring up that we need to talk about this stuff. This is what I want, and I want you to honor it. And they're like, let's not talk about that, just like you were saying, Kathy. And I think we absolutely have to teach this. That if you sit down as a husband and wife and do this when you're under no pressure, and then share it with your kids, it's a whole lot easier than trying to do this on someone's deathbed. So it's just,
Yeah, no, I really appreciate you saying that, because that's part of my hope here, is that unfortunately we end up having a lot of these conversations inside the hospital while someone is uncomfortable, maybe while they're on life support, and this kind of conversation goes much better if you're sitting in a chair drinking some decaf. You're able to think through things better and give things a little more time. Or the real stuff, yeah. If I drink the real stuff, I won't get any sleep tonight. That won't work out too well. Okay, I'll dive through some more terms, and then I'm hoping to give you all a very tangible way to sit down and plan through all of this for yourself. So a few more terms. One that I want to make sure I talk about is DNR status or code status. You may hear any of these thrown around. DNR stands for do not resuscitate. DNR stands for do not resuscitate. It means exclusively that if your heart stops, you wouldn't want CPR. We'll talk about that a little bit more. This falls under the term of code status, ranging from quote-unquote full code, someone who would want CPR, we press on your chest, we shock you, we put in a breathing tube, to someone who, if that happened, would want us to focus on allowing a natural death. Now, one thing that I want to make sure I emphasize here is that someone's code status has no bearing on any other parts of their care. If I'm going to be brutally honest, most people who come into the hospital who end up having their heart stop or they stop breathing, a very small minority of them survive to leave the hospital. Maybe 15%, depending on what you read. And very few of those who do survive end up leaving the hospital with the same kind of functional status that they came into the hospital in. And I only say this to say because if you watch TV shows or you watch ER or you watch House, you watch this young, healthy person whose heart stops, and then we press on their chest 3 times, and we run some electricity through their chest, and they wake up and they start talking to us. And unfortunately, that's not really how this usually works. On a lot of people, we can get your heart to start again, but that doesn't mean that we're really going to be able to get you to come back again. And most frequently, if you've been under the situation where you were to get sick enough, where your heart were to stop, you were to stop breathing, the illness that brought you to that point is still present at the point when we're trying to restart your heart. So even if we do have a quote-unquote successful code where we're able to get your heart to start again, that doesn't mean that we fixed the illness that got you there, and usually it means that we have an even worse handle on it. I only say this because, again, we have some particular experiences in healthcare where we go through some less than glorious codes, and you have a lot of people who get caught up on the idea that if I say that I don't want CPR, then they're not going to give me all the other treatments that I do want. And that does not mean that at all. Last week I was working on our hematology service with some cancer patients, and I had a patient who that day had decided that she wanted to be DNR. If her heart stopped, she didn't want us to do any compressions. That night she had trouble breathing, her vital signs got all over the place. I still sent her to the ICU. She still ended up on some drips. We were very aggressively treating her illness. All this means is an end point of if my disease is to get bad enough, what do I want to endure? What do I want to go through? That does not mean I'm necessarily giving you any particular recommendation for what your code status should be. That depends on your own personal goals and what you would want to go through, but I do want to make sure that I emphasize that if you decide that you want CPR or you don't want CPR, or you want a breathing tube or you don't want a breathing tube, that changes nothing else about your care up until that point. So we'll still give you antibiotics to treat your infection, we'll still give you cancer meds, we'll still give you blood thinners, all the other stuff. It really only touches that end point.
It's a standard question though now when you go in, right?
Yeah.
Automatically.
Yeah. It is a standard question when you come in. One of the, so that's what was said, is that this is a standard question when you come into the hospital. It's theoretically supposed to be. That conversation, unfortunately, usually ends up at around 2 a.m. after you've been in the emergency department for 6 hours, and I'm on my 4th admission for the night, and it ends up being a shorter conversation than either of us would like it to be.
One question along with that, and maybe you're going to address it a little bit later. People will often ask, if I'm a no code, a DNR, what happens if they want to offer me a surgical procedure? If people go for a pacemaker or even a surgical procedure, and maybe you could speak to that, Ben, because that people don't quite understand how that works.
Yeah, that's a great question, and I think the most honest answer is actually that it depends on what hospital you're at, because different hospitals will have different policies and procedures for what happens to code status around the time of a procedure. And codes in a procedural setting are a little bit different than codes in a floor or a different setting. Because if you're with me on the floor, if your heart stops, it's almost certainly because your illness has progressed to a point that we're no longer able to keep your heart going. There are more opportunities for complications when you're in a procedural setting. So some hospitals, Mayo here is one of them, will say that if you're going for a procedure, the general rule is that you have to be full code for the time of that procedure. Because they'll say, if you experience a code while you're in the operating room, that's probably because it's something easily reversible, that if we do some quick interventions, we can quickly intervene, we'll be watching everything in the moment. And those people tend to do pretty well if they do experience a code, because it happens very quickly and we almost always know what happened. And it may be related to a medication or a breathing tube or something else that we saw happen very quickly. So you may have some experiences where if you go into the hospital and you say that you don't want to have a code or you want to be DNR, your team might recommend that you go for a procedure, and then we do get this kind of awkward gray area where they might discuss with you, quote unquote, reversing your code status or having to be a full code for the procedure. That can and should be a conversation with you, and depending on who's on your team and depending on what hospital you're at, they may have different policies in place and you may be able to stay DNR during a procedure. But that is a point where we end up frequently having extra discussions.
Is it anesthesia's responsibility to do that then before you are?
To have the conversation with you?
Yeah.
Not technically. So technically, whichever team, if you're hospitalized and you're going for a procedure, whichever team you're admitted to,
Your primary care.
your primary team, whether that's a surgical team or a medicine team, are the people who are supposed to be having the conversation with you before you go to a procedure. That's Mayo policy. I can't speak to exactly what it lends you at any other hospital.
I'm wondering if anybody on the screen has questions. Do you have any?
Yeah, that's a great question. I'll stop sharing my screen here for a
Yeah, I
moment
think
so I
we
can
can
see
do it.
everyone. Everyone have any questions on Zoom?
We're just soaking it all up, huh?
Okay, well, then we'll
Thank you.
go through a couple more definitions. Okay, so the next one to talk about is comfort care. I mentioned that in association with hospice and in association with palliative care earlier. Comfort care is medical care aimed at keeping you comfortable and relieving symptoms, not curing an illness. So palliative care that I mentioned earlier generally provides comfort care that can be given alongside treatments aimed at treating an illness. But generally, I guess I should say that comfort care is usually happening closer to the end of life and is a conversation with you about where exactly you want to be aiming your priorities in a moment. The next one is terminal illness. A terminal illness, oh, someone entered. Let's let them in. So I was just saying that a terminal illness is a disease that is expected to lead to death. We do not have crystal balls. I cannot tell you exactly what kind of time frame that will be, but frequently if someone is diagnosed with a terminal illness, then we'll start having more discussions about things like goals of care and what someone would want to happen to them as we approach the end of life. An important point here to talk about is quality of life. This is someone's overall well-being, including their comfort, daily activities, emotional health, social interactions. This is probably my most individualized term, and my sweeping term here will not apply to you particularly well because your quality of life and what you receive quality from may be very different from the person standing next to you. We'll have conversations with some people who experience great quality of life if they're able to sit on the couch all day and stare at a TV. And other people who say that they're only experiencing quality of life if they're able to go out and mow the grass every 2 days. This is going to be individualized for each of you, but it's something to keep in mind as you're going through an illness or going through a hospitalization of how is my quality of life right now? What would I want to go through if things got worse? And then the last one that I have up here is goals of care. This is a term that you'll hear most frequently in the hospital or in the clinic setting. And this is really talking about what your desired outcomes are from a medical treatment, whether that's focused exclusively on relieving pain, if that's focused on maintaining independence, or if that's focused on living as long as possible. And one thing that I should say with each of these terms is that nothing you say during any conversation is set in stone. And all of this can be changed if you change your mind in 5 minutes, or in a half an hour, or in 3 years. So your goals of care in this moment may be different from your goals of care in 6 months. Okay. Before I move on to other topics, any questions about some of these terms that we threw out or definitions or things that you would like me to clarify or talk more about?
I kind of have it.
Yeah.
Because I'm single, I don't have any family anymore. If I make final decisions, who does that usually go to?
Oh, you're feeding me. Okay. We'll keep moving forward. Okay, so this is going to be the framework that we'll use for the rest of our conversation with a reference. I have this as a link here. I don't know if we're able to share the slides later, but honestly,
Yeah,
the
we'll be glad
website.
to. I'd send them out to everyone.
Perfect. Well, then once you have the slides, if you click on this link, it'll bring you right to what I'm talking about. But the framework, and frankly, what I stole a lot of this from, is a website called Prepare for Your Care. If you go into Google and you type in Prepare for Your Care, this will be the first website that you find. And it walks you through a step-by-step way, including videos that are going to explain this better than I do, for choosing a medical decision maker, deciding what matters most in life, choosing how much flexibility you want for your decision maker, telling other people about your wishes, and asking the right questions. For those of you who are here right now, you have a little trifold that has each of these written out. It says step 1, step 2, step 3, step 4, step 5, with a little blurb about each of those. But we'll dive through those on the next few slides. And I'm going to give that trifold to our other person.
I just asked, well, Patty was here, and she said, yes, you did a beautiful job on that.
Oh, well, that's good to hear.
And I'm sorry to be late, but I had an unexpected guest.
Oh, goodness, you're good. I'm happy you're here at all.
Yes.
Okay, so step 1 is to talk about choosing a medical decision maker. Brief argument for why you should do this if you're able to. Around 3/4 of people won't be able to make medical decisions at some point in their life. That might be at the end of life, that might be earlier on in life. But most people at some point have to defer to someone else to help make decisions for them. And doctors or your care team need to know who they can talk to help make decisions for you. Because like we mentioned earlier, these conversations tend to go best if they're had now in a more relaxed environment than when you're sick and you've landed yourself in the hospital. So this is an important thing to think about. The what of a medical decision maker is that a medical decision maker only makes decisions for you when you want them to make decisions for you. For most people, that's if you are unable to make decisions for yourself. If your team, after assessing you, says that you're not really able to grasp a particular situation and you need someone else to make decisions for you, then we would pull in a medical decision maker if you've named someone. Otherwise, if you just said, you know what, today's been a lot for me, I don't want to make any more choices today, you could also tell your team, talk to XYZ person to make this choice for me, even if you're able to make a choice. For most people, though, a medical decision maker only comes into play once you're at a point where you're not able to make decisions for yourself. The win of choosing a medical decision maker is ideally before anything particular comes up. If you're able to plan this ahead of time and have a planned conversation with that person and really talk to them about what your goals would be, then that helps set them up for success should you need them at some point in the future. Okay, so how to choose a medical decision maker and an example of this. So the person you choose as a medical decision maker is an important person for you. You don't absolutely have to have one. You can still fill out forms like an advance directive and a living will without having a medical decision maker, but it is, if you're able to think of anyone who you would be willing to trust, it can be really valuable because it's hard to predict every single circumstance you may run into in life. This person can be a family member, it can be a loved one, it can be a neighbor, it can be a niece or nephew, it can be a friend from church. It cannot be your physician or someone on your healthcare team. You can't defer to someone on your team to make the decision for you for everything. But this doesn't have to be a particular person. And then in the state of Minnesota, we do not have a hierarchy of who makes decisions for you if you're not able to make decisions. I only mention this because some of you may have had experiences in other states where a loved one or a friend was sick and they weren't able to make decisions, and the care team said, the first person we ask is the spouse, the second person we ask is the children, the third people we ask are the parents. Minnesota, as a state, does not have a particular law like that. There's not a certain person that I'm going to call if you're in a situation where you can't make decisions for yourself. I involve anyone who's, if you haven't named someone, I involve anyone who's an invested party, which generally means anyone who calls the hospital or shows up at your bedside, or anyone who I'm able to get a hold of on the phone. If you've named a medical decision maker, though, then that person becomes your person who is able to make decisions for you. You are also able to name multiple decision makers. generally as more of a hierarchical thing. For example, for me, my first decision maker is my spouse, my wife, Jess. If, God forbid, something happens to both of us simultaneously and she's not able to make decisions for me, then after that, it's my sibling. And then after that, it's my parent, so on and so forth. You're able to make situations like that. But once you have thought about who you may want to choose to be your medical decision maker, it's good to choose a time and place to talk to them about you wanting this. Make sure that they understand what you're asking them and make sure you give them time to think about it. This is one of the frequent downfalls here, is that you're sitting at the Easter dinner table and everyone's having a great time and you say, oh yeah, I was hoping to talk to you about what I want to happen in case I'm dying. They may not be very interested in that conversation at that point. Versus if you say, I was having a conversation at church the other night, or I went to my clinic and we were having a conversation about my health, and I wanted to start planning ahead for things in the future, and I was hoping to talk with you. If you can set the stage for this kind of conversation, it goes better. So an example I have here, it says, my doctor thinks it's important to choose someone to help make medical decisions for me. This is in case I get sick in the future and can't make my own decisions. If this happens, would you be willing to work with my doctors or work with my team to help make medical decisions for me? You're not hanging this person out to dry. We're not going to give them no guidance. But this is you asking them, if you aren't able to make decisions for yourself, would they be willing to help make decisions for you? Okay, before I move on from that one, what questions do you all have on choosing a medical decision maker?
For us, you could have 3 kids and they all have different ideas.
Yeah.
So that is very important that you talk about it ahead of time and make it sure it's your wish. Because when they're backed into a corner, then families are not united. So, whatever. One can say, Mom wrote this down and this is what she wants. And Mayo puts out a wonderful book for that it takes time to fill it out, but it's worth it.
Yeah.
It's very much worth it.
It is very much worth it. And that is a good point, that there is the possibility, if you're in a situation where you have multiple people in your life who would be invested in what happens to you, if you haven't named someone who you want to make decisions for you, that can potentially lead to some strife between people. There can be some heated moments in some of these conversations. And it is really helpful if you've been able to talk with them ahead of time, A, about who you would want to make decisions for you, and B, what kind of decisions you would want them to make. And it's important to point out, I didn't specify this in choosing a medical decision maker, but they are supposed to make decisions for you that are the decisions that you would make if you were there in that moment. It shouldn't be the decisions that are most serving to them. That is something that we try to evaluate on the back end. But that is an important conversation to have with them, is that they'd be making decisions for you about the decisions that they think that you would make if you were able to make decisions for yourself. So that's why this is the first step, because then you have to tell them what you would want to happen in different situations. What other questions do you all have?
Anybody?
Question from the Zoom call here.
Yeah, I can hear you, and I'll re-say it.
In the absence of a medical decision maker, whatever those circumstances might be, what is the default response of the care team? My understanding would be that they will do everything they can to preserve a life, but I could be wrong about that.
Yeah, so that's a great question and a really messy area. So he said, in the absence of an alternate medical decision maker, if something happens to you, what does your care team do? How do they move forward? You'll get slightly different answers from different people. The general answer is that your care team is supposed to hold up what they think a reasonable person would do in your situation. What that generally means in the US, where frankly we're in a relatively litigious society, is that we do everything within our capability to keep you alive and breathing and your heart beating. That does get really messy if that's not something that you would have wanted. Now, if even in the absence of a medical decision maker, if you have filled out some sort of advance directive or some sort of living will, then we will absolutely defer to that. If you find yourself in a hospital in the middle of the night with no one around you, and you've already said, under no circumstances do I want to have a breathing tube in, under no circumstances do I want CPR, I wouldn't want XYZ, or I would want XYZ. I know I look like I'm sick, but actually I have a really good quality of life, and I want to make sure that you do everything for me. No matter where you land there, if you filled out something and sent it in and it's in the system, then we'll defer to that on any grounds where it applies. We do get into messy situations if someone has no clear medical decision maker and they're new to a hospital system and we have no idea what kind of goals of care that they would want, where then unfortunately the most frequent initial steps are to pursue treatments focused on an illness, which may or may not ultimately be aligned with what someone would want if they were able to make decisions. That answer your question? Perfect. What other questions do you all have? Okay, great. And step 2 is maybe the most daunting task, which is to decide what matters most in life. And this is the one where I am most going to defer to you. So your doctors, your decision makers need to know what's most important to you. For some people, they say that what's most important to them is being able to sit down and watch the game on Sunday. For other people, what's most important to them is being able to make it to a family holiday in a few weeks and be able to engage with their loved ones. It may be things like playing with your pets, hobbies that you pursue, working, independence, your experiences here at church, your religion, or outside of the church. Maybe it's not being a quote-unquote burden on those around you. What is most important to you as you think about your life as a whole. And it may be entirely something else that I didn't even think of or mention. Another way to think about this is what brings you joy. What are you most looking forward to? It's not uncommon that we have people who say that right now what matters most in my life is surviving to my grandchild's wedding in 6 months. After that point, what's going to become most important in my life is that I'm comfortable at home. And you can have things like that where you say, I want everything to happen for the next 6 months. And if we make it to that point, then maybe let's stop putting me through some things. Or you can have anywhere in between there. These can really exclusively be whatever your priorities are. And the more information you're able to give your medical team, your decision makers, the more guidance you're able to provide for what kind of things you would and would not want to go through. Because as much as we would love it if we're able to present you with every possibility in the future, treatments change, and illnesses change, and situations change. And if we had had this conversation 5 years ago, none of us would have even known what COVID was. So things come up that we maybe haven't planned for. So it's nice to give people some sweeping strokes, some ideas about what's important to you. Because if we reach a point where we say, I'm not going to be able to get you back to enjoying your family member's company, then that would be an important line in the sand for some people, saying, well, then I don't want to go through this because I'm not going to get back to what matters most to me in life. Versus I might say, we'll be able to get you back to enjoying time with your family, but the route to that is going to include a lot of time in the hospital and a lot of, unfortunately, expense and probably a few months in a rehab facility. And some people may say, you know what, I really value my independence. I don't want to go through any of that in the meanwhile for a not guaranteed future. That's also an extremely reasonable choice to make. So deciding what matters most to you in your life is really important. And another way to think about this is what tasks are there that you need to do to make life meaningful? If you're not able to walk your dog in the morning, is life no longer worth living for you? And I don't mean that to sound like a dark statement. That's really just a really honest thing. I want to every day be able to walk down and get the mail. We may reach a point where you're not able to walk down and get the mail. Or I want every day to be able to sit up in bed and feed myself food. You may reach a point where you're not able to sit up in bed and feed yourself food. So there's kind of this idea thrown around. I didn't throw this up here specifically, but like a minimum necessary task. Something that if you aren't able to do it, you wouldn't want to continue going through other treatments or other things aimed at an illness. These are important things to think about of kind of where's some semblance of a line in the sand for me.
And could I just interject one thing?
Yeah, absolutely.
That's one thing I really appreciate in the Mayo Advanced Directive, is they ask, just as you said, you choose not to be resuscitated. By that we mean CPR, like you just described, but it also says there's a checklist. What if I can't feed myself?
Mm-hmm.
What if I'm bedridden? What if I depend on others to get me wherever I need? There's degrees of severity, and it really makes us think about what we value.
Yeah.
I mean, would we be happy lying in a bed if we were paralyzed, but yet our family was around?
Mm-hmm.
And those are really thought-provoking questions.
If you're able to lie in a bed and hear other people sing, is that worth living for you? For many people that may be, for other people that may not be. If you're lying in a bed and you're not able to sing, then does that become a different question?
But I think your point is well made, that what's right for you and right for me or right for her, it's different and it doesn't matter.
That's correct.
As long as you have discussed it with family and your doctor. It doesn't make me better or worse. It's what I want.
Yeah.
And I think if people just understood that, to think through these things before you need to. Like Kathy was saying, I'm impressed with Mayo's booklet.
Yeah, no, they have a really good document.
And it can be changed.
Mm-hmm.
People need to be aware of that. It's right up front. If you want to change it a year from now, get another book and start over, and they scan it in. But I don't think people realize that either.
And I think I should also mention, I really appreciate the point about that's not right or wrong. This is an area where you can frequently feel like you're dealing with questions of morality. And I don't really want you to feel that way. For a lot of these things, we're not talking about some hot topics that we could dive into, but for conversations like this, deciding what you wouldn't want to go through is not really particular an area of morality, especially within our, I'm going to assume that everyone here is Lutheran for a second, especially within our tradition. It is very clear that we are not a quote-unquote vitalistic philosophy, where we say that life is worth maintaining at any cost. That is very not in line with our line of theology. So you shouldn't feel like if you decide you don't want to go through a treatment that you're giving up or you're failing in some way. That means that the course of nature has continued in your life. And unfortunately, all of us are going to pass from something. And if you're in a situation where you're able to decide that this is what I'm probably going to pass from, that is not a question about good or bad, or morally right and morally wrong. That's a question about what you want inside of your life. Yeah?
Just got one quote that I remember from years ago. I heard it actually on a movie. And one thing that kind of caught my attention is we have one life and we might as well live it to the fullest, because we never know when God's going to call us home. And to this point of everything that's gone through my life, I feel like that's what I'm trying to do right now. So hopefully in 2 years, 3 years at the max, I will have my master's in financial advisement.
That's great.
So
I want to say it's very impressive that in light of the circumstances you're going through, that you're able to maintain a vision for a future. That's, I'm sure, not an easy task.
I think that's a good example, Darlene, of making our choices, because we don't know what will come our way. And to be able to know that people are aware of what we want, whether it's our attorney or someone that can be our advocate.
So the next part of this that I said is just when you're thinking about what matters most in your life, is to think about prior experiences you've had with serious illness, whether those are experiences you've had with yourself, or things that have happened to friends or family, or things you've frankly seen on TV. You may talk with someone else in your life who watches something on TV and says they would want to go through all of that, and you may be sitting there and say, I would never want to experience any of that. It's helpful to think about different things that you've seen or things that you've seen people go through, and ask yourself what went well, what didn't go well, what would or wouldn't you want to go through. And then just to really drive home the point, I think for about the 12th time, the quality of life for someone differs for each person at different times. And this said, the medical group needs a copy of your advanced directives with copies for other, not kept only in a safe deposit box and accessible. That is a very important point. If you think through all of these things and you never tell anyone, or if you write them down and you put them in a firebox in your closet, that doesn't do you much good when an unanticipated health thing comes up and you end up in the hospital in the middle of the night. I'm very, very happy to defer to any of your preferences. I'm not able to do that if I don't know them. So if you do put through the legwork to think about these kind of things, maybe write them down or talk with someone, please make sure that you then give it to your doctor, your clinic, your hospital care system. If you're someone who snowbirds in Arizona or Texas or Florida, send it to the hospital down there. Make sure that wherever you go, they're able to have something on hand, that if something happens to you, they're able to defer to your judgment instead of me trying to guess what you would want, because I'm not very good at guessing. Perfect. And then just threw this up, because people may land anywhere on this continuum, sitting on one side where they say their main goal is to live life as long as possible, no matter what, all the way to my exclusive goal is to focus on quality of life and being comfortable. And you may find that you land anywhere on that continuum, and that's fine, but it's an important idea to have some sort of idea of where you are on this. So I considered this the most daunting task, so I made some extra slides on it. So the other thing that I said here is, you can ask yourself, if you were so sick that you may die soon, what would you prefer? You may say you're not sure. That's completely fine right now. You don't have to have answers to any of these questions that I'm throwing at you. On the other hand, you may say that you want someone to try everything, even if you're unlikely to survive. You may want to trial things for a short course of time, or you may want to focus exclusively on being comfortable and having a natural death. That middle one is something that some people will say, I would want everything in the hospital for a week. I would be willing to be on a ventilator for 3 days. If I get better, then great, I got better, I got through it. If I went through something like that, if I had a trial of treatments and I wasn't getting better, then I don't want to go through that anymore. So you can land anywhere on this continuum for what you would prefer in different situations. Another important question to ask is, if you were at the end of life, where do you want to be? And how important is that to you? Very few people want to pass in a hospital. A fair number of people end up passing in a hospital. If it is of the utmost importance to you that you die in your bed at home, then tell that to us. Because once we reach the point where I say, I'm no longer certain that I can get you back to your bed at home, that might be a line in the sand where we say, maybe this is where we make sure that we get you out of the hospital. Maybe this is where we stop talking about particular treatments. So if you have a hard line in the sand, something like that, write that down and let us know. And what else is important? Food, music, pets, people. If you're not able to feed yourself, is that a line for you? If you're not able to take solid food, is that a line for you? Now I'm throwing out lots of things which can sound really, really overwhelming. I don't mean it to be. You don't have to have answers for all of these things, particularly if you're able to have a conversation with someone who you would trust to make decisions for you. And you can give them an overwhelming idea of kind of things that you would or wouldn't want to go through. And then here, like we said, none of this is set in stone. It is okay and normal to change your mind. Hopefully, going through these types of questions helps you think about future scenarios. You're not going to think about every possible scenario you may run into, but if you sit down and think about what kind of food would I be willing to go through, that may help you answer questions about an entirely unrelated subject that may come up for you. Or the way that you think through something may give your medical decision maker information about how you would think through something else. The next ones get a little bit shorter. Step 3 is choosing a level of flexibility for your decision maker. So if you have thought of someone who you would be willing to make decisions for you, and you've thought about different kinds of scenarios that you may or may not want to go through, This question is, what is it okay for your decision maker to change, and what is not okay for them to change? It's hard to predict everything. There's new situations, there's new treatments. Some people want total flexibility, and they say, if I'm not able to make decisions, you are allowed to make any kind of decision for me that you want. Some people give no flexibility. You have to follow the letter of what I have written down perfectly. That can be a little bit messy. And other people choose to limit flexibility. They say the hardest line in the sand for me is that I want to pass at home. If you ever run into a situation where that's not a possibility, then I'm done. Or the hardest line in the sand for me is that I want to be able to feed myself solid food. If you run into that possibility, do not overstep that line. Even if the team says a feeding tube may only be a thing for 3 months, that may be a hard line in the sand for you. Other people may say, you know, I really like to be able to eat food, but if the team says that I'll need a feeding tube for a few months and then they think I'll get better, then I'm okay with you making that kind of decision. So it's nice to think about what level of control do you want to be able to have if you find yourself in a point where you're not able to make your own decisions. Are you willing to defer a lot of things to a decision maker and say, these are kind of my overall thoughts, make decisions as you think I would? Or do you want to say, these are the exact points and I expect you to fulfill them as I've written out? And same with our what matters most in your life. There isn't a right or wrong answer here. And then after you choose how much flexibility you want a decision maker to have, it's important to tell them how much flexibility you want them to have. That one's real short. What questions do you have on choosing how much flexibility you would want a decision maker to have for you? Okay. So step 4 is telling others about your wishes. People you should think about telling your wishes to are your decision maker, your medical providers, your family and friends. Even if you have, say, 3 children and you would say, you're the one I want to make my decisions, it can still be helpful to tell everyone else, A, this is the person that I would like to make decisions for me. And also B, these are kind of my goals or my wishes. Because if you do have people who would be invested and you would want them to be able to have conversations about your care, it can be helpful for a group to be able to talk and say, you know, Mom said that she wouldn't want to go through this, and I think that that applies in this situation. On the other hand, this is a slightly darker statement, but depending on your circumstances, you may also say that there's someone in your life who you would want to make sure isn't involved in your medical care. And you can say that also. You may say, if my niece from Chicago shows up at the hospital, I don't want you to tell her anything. And that's fine. Or it's just, this is all within your control of who you would or would not want to be involved in these kinds of decisions. If you have 3 kids and you want one of them to make decisions for you, but you still would like the other 2 to be able to be involved, that's fine. It can be helpful for them to be able to defer to someone. But you could still have conversations with all of them about what kind of goals or what kind of quality or what kind of treatments you would want to go through. Any questions about telling other people about your wishes? Okay, good. And then the last one is really something about moving forward. It's about asking medical providers the right questions as you experience things or as you meet kind of turns in the road. It is always extremely reasonable for you to ask about risks, benefits, and alternatives of what you're being proposed. If your team wants to start a new medication on you, you can ask about the risks, benefits, and alternatives. Technically, they should be talking to you about all of that, but sometimes clinic visits get a little tight. Ask about the treatment course and outcomes. What will life be after a treatment? Maybe you're thinking about having your knee done because it's been giving you lots of problems for a while. And in a year, they expect that your knee will function really, really well with surgery. What you may want to ask about is, what is the next year going to look like? Am I going to need to be hospitalized? If I am, how long do you think I'll be in the hospital? Will I be able to go straight home from the hospital, or will I have to go to a rehab facility for a while? Try to get an idea of what an entire treatment course would look like before you start down something. And you can also ask, what are the risks, benefits, and alternatives? Maybe the alternative is that you get a steroid injection in your knee every 3 months, and that might progressively worsen your knee disease in the distant future, but maybe you're not too worried about the distant future. Or maybe you really wouldn't want to go through a hospitalization. It's important to know what kind of alternatives are available to you and what the entire treatment course of something may look like for you. Granted, none of us ever have a crystal ball, but we're able to predict some things.
That, you know,
Yeah.
I had a knee replaced,
Uh-huh.
and that doctor was very concerned about what my support system would be at home afterwards, because, you know, because for a while you need somebody to get you to appointments, and you know, that, so, and when my husband had it done, I wasn't with him, and he kind of, the doctor kind of hesitated on whether they should do it or not, because such an old guy, and
Don't tell him you said that.
We won't mention it.
Don't tell him you said that.
he'd go along with that.
He'll agree.
Yeah, he would. So, that's really important, and if you need to have rides, who's going to take you?
Yeah.
And who's going, yes, there's a lot, even to have a knee replacement, which I think is really not very hard
Yeah.
afterwards,
Mm-hmm.
so, yeah.
Yeah, no, there's a lot of logistics that go into anything. If you have to be able to be in a bed for 2 weeks, maybe you make all of your own meals. How are you going to get to the kitchen? Who's going to bring food to you? These seem like really simple questions, but they can complicate things really quickly. And part of that, with you showing up and then saying maybe we can do something, is before a visit, think about writing down questions you have, but also it'd be really helpful to bring someone with you. A, that might demonstrate some of the people around you, and B, 2 people are generally better at remembering things than 1 person, and it can be nice to have someone else to bounce things off of. During a visit, if you did write down questions, tell whoever you're seeing, preferably near the beginning of the visit, that you do have questions. If you see me in my clinic, and we've been together for the last half an hour, and now I think we're wrapping up, and now you mentioned that you have a page of questions, I might not have time to answer your questions. But if you come in with a page of questions and you say at the beginning, I might say, okay, we really need to talk about this medication, let's talk about this medication, and let's answer all of your questions before I go into a bunch of other random stuff that may or may not need to happen right now. So before you go into a visit, if you have particular questions, it's helpful to write them down. You're guaranteed to forget them if you don't. And tell whoever you're seeing, preferably early on in the visit, that you do have questions you want to make sure that you talk about that day. And then as you're talking about things, it's helpful if you try to reword things back to whoever you're seeing. If you put things in your own language, and me or whoever's talking with you will be able to hear if we're actually communicating to you what we're trying to say. I want to give you a new blood pressure medication because I think it'll reduce your risk of heart attack and stroke in the next 10 years. You can say back, okay, it sounds like you want to start a new medication on me that I would take once a day with the goal of reducing how likely I am to have a stroke in the next 10 years. I'll say, yeah, that's right. And then you might say, that sounds great, or you might say, I'm not interested in any medications. Okay, but now I know that you understand what we were talking about. And if you had that wrong, you say, you want to give me a blood pressure medication so it lowers my numbers. Well, that's not really what I'm targeting. We're talking about something else here. And then there's a conversation that can come in so that I make sure, and you make sure, that you understand what's happening in your care. Because it's no use going through this conversation of deciding what kind of goals you would want if the care that you get along the way isn't actually aligned with that. So the summary of today, and then we'll open up for any remaining questions, is we discussed the definitions of some important terms that come up in this arena. We went through 5 steps to prepare for your care. Step 1 we talked about was choosing a medical decision maker. Step 2 was deciding what matters most in life. Step 3 was choosing what level of flexibility you would like for a decision maker. Step 4 was telling others about your wishes, and step 5 was making sure that you ask the right questions as you approach new scenarios. This was the site that we use. I took a screenshot. This is what their homepage looks like if you choose to use this. Mayo does have a really good booklet, and they tend to try to give it to you at any appointment you go to. If you fill that out, that is also a great resource. Some people prefer online, some people hate online. I just bring this up because this is really an extremely easy website to use. I have absolutely no ties with them. But really, if you click here to do your own medical planning, it will walk you through every single step that we talked about today, with more examples and videos that talk about how different people think through things. And if you write in your answers to questions as you go along, at the end you can print out an advanced directive that says everything there. If you don't like using computers, you're not able to, maybe you have someone in your life who you think would be your medical decision maker, who is able to use computers, and that can also be a nice conversation aid if they said they're willing to do this with you. If you walk through these kind of questions with them, this can be a nice way to have a conversation about what you would and wouldn't want, and then they can type it into a document. You don't have to use this, but it's a convenient site, and that's where I got those pamphlets that I gave you from. Okay. Yeah.
With this brochure, because I kind of just started.
Yeah.
Because I'm not too sure, I have a laptop, but I don't know where to go and use it now. So basically, if I did it, I would possibly do that, and will that go directly to my doctor?
So you will have to send it to your doctor after you fill it out,
Okay.
but you would be able to do that on your phone. Yeah.
Because right now, I think I'm kind of open to which doctor I need to send it to, because I've seen too many doctors that kind of.
It just goes on your general mail record.
Yeah.
So whoever takes care of you, it would be there.
Yeah, that's correct. I guess I should specify. This doesn't have to be sent to a particular doctor. You can think about it more as like the healthcare system at large. So if you sent it to Mayo, for example, it doesn't matter if it goes through me or someone else. It'll end up in the same place in your chart. And then we know that we're able to defer to it.
It has gone to so many different clinics, and basically it's just going to.
Yeah. Yeah, if you do have questions about who's technically assigned as your primary person within Mayo's system, if you call their general number and just ask them, who's my primary care provider, they should have a name for you that they're able to give you.
Okay, because I think just recently I was told that my doctor's at the bottom.
Okay, yep. Yeah.
Other questions in the room or on the
We
screen?
have a question on Zoom.
Oh, good.
About 2 weeks ago, I was talking to my conversational English class that if I passed out in class, please do not send me to Mayo because I'm an Olmsted clinic person. Of course, they are researchers at Mayo, so they all said, hey, we're all doctors, we'll just take care of it. But I am asking because I might be somewhere else and pass out. And I've been told that the ambulance will automatically take me to Mayo, but that's not where I doctor. So do I have to wear a sign or something that says, please don't take me to Mayo? What do I do?
That's a great question, and that gets messy depending on what kind of situation you find yourself in.
Can you repeat the question?
Oh yeah, that's great. I should probably do that.
I didn't hear it.
Yeah, she said that, for example, I'll preface some things, but she was in one of her conversational English classes recently and informed all of them that if she passes out, she would want to go to Olmsted because she's an Olmsted patient, not a Mayo patient. Extremely reasonable thing to say. But then said that she's been informed that the ambulance system automatically takes you to Mayo. How do you relay something like that of I want to have care here, not here? That does get particularly messy because it depends on the exact situation you find yourself in. So let's say that you were at home and you were choking and you called 911 and the people who got there weren't able to talk with you. Most likely the people in an ambulance are not going to be able to find an advanced directive for you or some sort of clear thing. And really the guidance there would be that they take you, if you're in that kind of emergency, to whatever the closest hospital is. Whether that's Olmsted or Mayo, or if you're somewhere else, any number of different systems. If you are able to advocate for yourself and say, I would like to go to Olmsted, then that's an extremely reasonable thing to say, and they can probably do that. You do run into some barriers depending on where exactly you are. For example, there's some services that are offered at particular hospitals that aren't offered at other hospitals. So if you need to have a procedure on your heart, you might be taken to one hospital versus another in any given town. So unfortunately, that particular scenario is actually pretty hard to plan around because it depends on what exactly you experience in the setting of an emergency. One thing you can consider if in like the setting of your own house is that some people will post an advance directive or maybe some sort of abbreviated form that they've signed and their loved ones or decision makers or their care team knows about, that's in an easily accessible place in their home. Say, for example, you would never want to be coded or have a breathing tube in. You may, if you live on your own, you may want to have that somewhere where if an ambulance team shows up, they would be able to easily reference it. And something like that where you would say, if medically possible, I would prefer for my care to be at Olmsted County. That's absolutely something that you could put in that. Now, depending on the exact situation, they may have to take you someplace or another, but that's an extremely reasonable thing to have written down. Did that answer your question?
I have a, should we stop sharing and see?
Yeah, sorry.
No, that's right. Let's see everybody.
Yes, we have available at Redeemer, they're called File of Lives. And they have your doctor's name and your funeral name, everything on there, the medications you're on, and they're really thorough, and your family names. And they're very thorough if they're kept up to date. And right now mine are not up to date because I'm on some new meds and stuff. But, so Kim, why don't you stop sometime and I'll get you that file of life. And I give it to any one of you. I have a few in the
We can get
nurse's
more.
office.
We can get more too, can't we?
Hmm?
Maybe we should get more and keep some on hand. if we
There
need
are some on hand.
Good, okay, good.
There
Perfect.
are some, yeah.
She heard you and said thank you. You can't hear her.
You want to put everybody back on the screen and
Oh
see-
yeah, that's a good idea.
see if that'll generate any questions from the audience.
Yeah, I do. What is that?
What other questions do y'all have?
Hi, this is Starlene,
Yeah.
and mine are just more some comments, particularly since my mom just died. And last year when we were selling her home, I did come across her own obituary that she had written. And I had mentioned it earlier that I had a draft of my own. I didn't realize she'd written, but it was so easy for the people left behind because she had these facts and details that she wanted included. So to me, that was a gift for us. And I think it's also important for people to know if you are an organ donor, no matter what your age, because even though she was 99, the person coming to collect her body did ask about organ donation because even later in life, you can donate your eyes or skin. And one other item is I'm part of the Mayo aging study and I'm donating my brain to Mayo for whatever they want to do with it. But to me, that's important, as well as whether or not you might want an autopsy for you to determine cause of death. In my mom's case, she died as a result of a fall and bleeding on the brain, which is automatically calls for a medical examiner report in Minnesota. So all kinds of things to consider, whether it's cremation, traditional or green burial. Do you have a plot already purchased. All kinds of end of life things that would be good discussion items.
I'll put one plug in. I know we can't support any one organization, but I'm sure you're aware that the funeral homes in Rochester and surrounding areas, you know, they have people designated just to help you do planning. And Dave and I went to a presentation. It was just fabulous about, you know, what you have to do if you haven't done any planning, what you have to do if you have, and what it provides for your family. And they're wonderful in helping with that. And then they keep it on record, and so then when we pass, it's right there, and they have all of our wishes. So that's relatively new, I'd say, in the last decade. But all those things you mentioned, Darlene, are on the advanced directive from Mayo, I believe.
Yeah.
And again, remember, that isn't set in stone. You can change it. You can fill it out, but it gives you a start, and then you go back and change it if you need to.
Yeah, and that is a really good example of, we focused mostly on thinking about this as something you do for yourself, which is a very reasonable way to approach this. You can also think about this if you do have loved ones or people who would be invested in your life or after you pass. This can also be a way for you to think about ways that you're potentially able to continue serving them. Because if you're able to give them clear guidance on what you would and wouldn't want in different scenarios, and then after you do pass, things that you would or wouldn't want to happen, or if you're able, like that example, or if you're interested in writing your own obituary or putting down things that are really important to you that are mentioned, that can be a daunting task for someone after you pass. And if you are able to gift that to whoever would be doing that for you, that can be a nice way to be able to potentially continue serving them even after you've passed on. Yeah.
One quick note that I want to share is I had bought a hymnal. It's an old hymnal that I grew up with my parents. And basically it has their memorial, you know, ornament of the fall. And on the inside, I have listed all of these songs that I grew up singing. And the beautiful old love hymns that were back in the 60s. And basically, I wrote them all down, and I feel like I want to kind of take all of them and just list them and just say, when I die, sing all these songs and sing them loudly and harmonize it.
Darlene is just talking about all the things, you know, and I think a fair number of people have family Bibles that have part of the family tree or wishes in them. But if you find a document like that, like we did with my mother-in-law, it was wonderful. I mean, she'd written out her whole obituary. And we had a class a few years ago on doing that. We should ask about having a class again, right?
Isn't there something on file at Redeemer?
Yes.
Mm-hmm. Yes,
Redeemer,
yes.
you fill it
We have a
out.
form here at Redeemer that you can use for your obituary.
Pastor Henning,
Yep, and it's wonderful. It starts you out, and you can put hymns down, but you can go back and change them. But what a gift again to your pastor and the staff. And it's what you want. Isn't that what's important? We hope so.
It just made me feel so good because when I bought that book, when I bought that hymnal, I mean, it just had all the old, beautiful hymns that we sang at my home church. And it just brought back so much memory of my dad, you know, especially during like offertory. He'd be up because he worked as an elder in the church. And basically, I used to just always feel so proud that he was serving the Lord in this way. And basically, all those hymns were just, it's just like a godsend.
But even having contemporary music, a lot of people today like contemporary music, and whether we have our choir sing it or, you know, whether it's taped, I mean, it's individual preference, but the important thing is to get it down.
Yeah.
And like I said, they're all written down in front of that hymnal, and it's in my back seat in a box, just right on top.
I have a donation question.
Yeah.
I have seriously thought about donating my entire being, but I do not want it to cost my family to send my body wherever it would go. So can you give me information? I've looked on the internet. This was before I lived in Rochester, and I've only been here 2.5 years, but I don't know Mayo's process for that, or if there is anything, or if it has, I thought it might be Vanderbilt where you could donate your body and not cost to pick it up or something. I don't know. But do you know how I could find that out? Do you know where I would go on the internet, what I would do?
Ooh,
Funeral homes provide that.
perfect. I was gonna say, honestly, that's a great question that I don't
Yeah,
have
I
a great
wondered
answer
if
to.
Randy had one that from Mayo, because anybody have an answer for that? Kim's asking where you could go to find out more information on donation. I would think if you have a doctor at Olmsted or Mayo, you could ask them and they would find a resource. Social workers know.
Yeah.
You know, there's a lot of information. Just ask, and that shouldn't cost you anything. It's like asking for an advance directive.
And Olmsted would have an advocate.
Oh, yeah.
Yeah.
Just ask your doctor.
I just thought you might know. Thank you.
Yeah, no, sorry, I'm not certain offhand, but
Okay.
we should be able to figure it
You
out.
got enough answers for us. That's one. One. Yeah.
Because of medical school and physical therapy, Mayo is always in need of bodies for the students to be working on. And from when my son went to medical school at orientation, I believe this when they said there was no cost to families if they wish to donate. And if you want the body back, then you can have it at the end. Or if you want them to take care of it, they'll do that also. They put the ashes out at Oakwood Cemetery in the big collection box of Mayo patients that have
Yeah.
donated.
That's changed, Darlene. That's changed some.
They won't always take it, is my understanding. If they have an abundance, then they don't. But if they need it, then you're allowed to do that. That is the way it always was. You know, so it's kind of a hit and miss.
And
So
so
you may want that, but they may have an abundance and they can't take it.
And they'll tell you that right up front. I've had people that have been told that, you know, who are terminally ill, and they'll ask, and that's right now, we can't take bodies, but be sure to indicate that, and we'll clarify it. Yes, it's been wonderful. Ben, thank you so much. What a timely and well-needed topic. All the people at home can applaud too. I told them we'd like to do this for a forum. Maybe again, you know, for the whole congregation in the fall. It'll be recorded and it's going to be on the website and people I'm sure will listen to it. But it's just such a timely topic and it's wonderful. We have a health professional that really likes to address it. So he's given us a lot of food for thought. Anybody realize that? We have some assignments here. But just to learn about this and just start the process so we know that we're providing the information we want for our loved ones and all the choices people have. He's just opened up to all the possibilities. So many, many thanks.
Of course, I may have left you with more questions than answers, but hopefully they're good questions.
That's good though. We're learning. We're learning.
In regards to the Redeemer form, Chris just told me a day ago, if you filled it out, she will keep it in your file here at church.
Did you hear, Joan? If we fill out the form Redeemer has for our funeral, they keep it here.
I'll keep it in your file here.
And that's a very same kind of form the funerals have too. And then you list your church and they communicate with them. Yeah, it's wonderful. It's come a long way.
Yeah.
Well, one thing, again, we thank you so much and we will be tapping you again.
I look forward to it.
One thing I wanted to say was,
Work tomorrow morning.
yes. We probably will not be meeting June, July, and August. We did that last summer just because people's lives are so busy. And we always meet the second Monday because that's what the congregation wanted when we surveyed. So the second Monday in September would be the 9th, which is Rally Week. And so we might just start off the fall with the third Monday, which I just peeked as the 16th, just because that stays away from all the beginning church year activities. And then we hope to have a lineup of speakers. So we hope you can all join us. And thank you so much for everybody being online here. I hope you can hear okay. And can we please end with the Lord's Prayer? Blessings to you all. May you have a good summer. And thank you for joining us. We'll look forward to having you in the fall. Thanks, everybody. Bye-bye.